Good afternoon. My name is Catherine Mayo. I'm a student at the University of Texas at Arlington pursuing my graduate degree, and I'm here to present to you a comprehensive strategic and marketing plan for a discharge lounge at my facility, Baylor-Scott White Medical Center of Temple. So Baylor-Scott White Medical Center of Temple, lovingly referred to as Temple Memorial as its legacy name is called within the system, is a level 1 trauma center, and it is the largest hospital in the Central Texas area. By size and by benchmark, it has no competition. More than 700 inpatient beds are available at any given time at this facility at maximum capacity. Currently, the facility is running above capacity because of the demands of the COVID-19 pandemic. This facility serves a diverse population ranging from ages 16 and up with various socioeconomic backgrounds from the very affluent to the indigent. We serve older pediatric patients based upon acuity, medical need, and on a case-by-case basis. Across the street we do have a children's hospital, McLean Children's, and we have an LTAC, a long-term acute care hospital, in the same city. We have over 30 clinics serving the area that are associated with the Baylor-Scott White healthcare system. Temple Memorial itself maintains a 63% market share in Temple and a 47% market share in Killeen and the Harker Heights area. Competitors on a smaller scale include Seton at Harker Heights, Metroplex of Killeen, and the VA system of Temple. Our service lines are diverse as our patients' needs are, and we have award-winning specialties in heart failure, cardiovascular, and orthopedic surgery, and cancer care in the oncology and hematology departments. We are also award-winning in our labor and delivery and maternal care services. So our model of care at Baylor-Scott White Health is called the patient-centered care delivery model, and it involves 4 key concepts. Our care is patient-centered, involving patients in the decision-making process, which makes this model of care also collaborative. And our collaboration is not limited to patient and care team. It is also expanded to mean collaboration between service lines and between professions. Doctors, nurses, respiratory therapists, administrators, financial advisors are all working together for the good of the patient. Our care is coordinated using a vast network of case management and care coordination services that safely escort a patient from the outpatient areas into the inpatient and even the acute care and intensive care areas and back out to the outpatient care areas without any interruption. And finally, our model of care means that our care delivery is accessible. We spend a lot of money and a lot of time focused on telehealth and remote care access points so that our patients who are confined to remote areas can still receive care from our team. This expands our geography and makes our patient care more convenient for patients who are geriatric or who have mobility issues or who have transportation and socioeconomic challenges. The model of care also contributes to the understanding of the nursing professional practice model at Baylor-Scott White Health, which is depicted here. Essentially, the core of this professional practice model is a cooperation between nurse competencies and experience, patient needs, and the environment of safety that we continually maintain to produce a synergy which escorts a patient using a safe passage method in and then out of our care organization. We are very passionate about performing care with no harm at Baylor-Scott White Health. Or wait for EMS or transport vans as appropriate. There they can also receive rudimentary nursing care interventions such as patient education and basic infusion therapy while they wait. This project started when a financial assessment of this facility revealed a potential lost revenue of $4.5 million per year in poor throughput practices. Due to pure inefficiencies within our system, we are losing millions of dollars. Now, this value is calculated from a lot of different sources, including ER inefficiencies with high rates of left without being seen or left without completion of treatment, and high rates of ER boarding. Patients who are waiting in hallways for acute care beds that are failing to reopen. That accounts for $1.5 million per year, according to our estimates. Also, $3 million per year could be lost by OR and PACU inefficiencies, poor turnaround, and high acuity and high census in ICUs continuously, year after year, produces millions of dollars in OR waste because of wait times and because of PACU boarding. A discharge lounge can help recover thousands of dollars in lost revenue per year. But this project is not small. It will take 3 years to implement. In the first year, the first 6 months will be dedicated to renovating a new space for the discharge lounge. That will cost roughly $300,000 in startup, but by the end of the first 6 months, we'll be ready to operate with 2.5 FTEs of RN staffing and 1 PCT FTE. A maximum census of 12 patients is to be expected by the end of the first year. By the end of year 2, we will move to maximum capacity. The first half of year 2, we will expand our staffing and expand our supply to serve 24 patients by month 18, and by month 24, again, we will expand to our maximum capacity of 36 patients. Year 3, we will see more return on investment than in the previous 2 years, and we will hopefully maintain that maximum census of 36 patients. Okay. The Discharge Lounge presents a unique opportunity for Temple Memorial to improve Baylor-Scott White Medical Center and Baylor-Scott White Health public image through marketing. So in order to recruit staff for this new area, we can focus on internal recruitment to avoid onboarding costs and training. In fact, we have a class of nurses who are ready to go and ready to transition into this new area called discharge nurses and case managers who are RNs. These nurses can be easily retrained to provide specific education that is DRG specific. For example, if a patient had heart failure and it was a new diagnosis, these nurses could be trained to provide essential education to prevent readmissions. So some of our other marketing plan ideas included using the digital billboard right outside of the facility. I'm aware of a current contract that we have for this digital billboard in place. So while the estimate for a 3-month contract on this billboard is up to $24,000 for one advertisement, we're already paying this money. We can easily replace graphics and save ourselves $24,000 in marketing by just using what we already have. In addition to the digital billboard, our team recommends social media platform marketing. If we spend $10,000 in Facebook marketing, we pay for up to 10,000 impressions. This is an overestimate in what we would need to get our public image to reflect this new area that caters to patients' convenience, safety, education, and a lower ER wait time. There are interventions that we can use in marketing that require no financial investment on our end. Baylor-Scott White Health maintains a blog called Scrubbing In. From time to time, there will be interventional highlights and marketing techniques used on this blog site that, because Baylor-Scott White Health maintains it, does not cost any extra to this facility. Around month 6, we recommend that the digital billboard receive a new graphic for a 3-month contract ending at month 9 to publicize this new area and improve public image. Social media marketing could start at the time that the billboard advertisement is completed, from months 9 through 12 or even 9 through 18, depending upon how much funding we are willing to contribute toward that end. The scrubbing in article we recommend is published at the end of the first year of operation, or month 18. Press releases cost us nothing. They also are funded by local news networks such as KCEN and local channels, local radio stations. Whatever publicity that this garners that has nothing to do with our financial investment, nevertheless, we will support it with our marketing and graphics design departments within our facility. So service line, the Discharge Lounge would be considered essentially another clinic. It would be an ambulatory cost center, and it would be separate and new. It would not be included in ER or PACU cost centers. It would be its own entity. The management hierarchy for the service line, we recommend, because it is ambulatory, that at the very least that it falls under the hierarchy of the Vice President of Ambulatory Services under the CNO. We also recommend that the interventions in the Discharge Lounge are nursing driven, but are overseen by the CMO and the medical service line and medical profession to a limited extent. Again, patient population will increase gradually. By the end of the first year with 12 patients, that doesn't leave a lot of room in our census, so we would like to focus on Medicare bundled DRGs that are at risk for a lack of reimbursement due to 90-day readmission rates, such as sepsis and heart failure. In the first year, we would also limit our admission criteria to patients who are ambulatory or who are standby assist at maximum. By the end of year 3, we hope to expand our qualified DRGs to include diabetes, limited outpatient-like procedures such as TAVRs, such as electrophysiology interventions like pacemakers, and other interventions such as low length of stay orthopedic surgeries. Our volume projections, again, in the first year, the first 6 months, represented here from January to June. We would not receive any revenue, and a $300,000 startup cost is recommended for renovations and for additional supplies. This would include staffing and an Omnicell. Patient census by the end of the first year would be at a 12 patient maximum. This value in this graph is calculated from the trends put forth by the year 2017. The initial staffing level starting in the 6th month of the project, again, would be 2.5 registered nurse FTEs and 1 patient care technician FTE. The operation hours of the Discharge Lounge would be limited from 1000 to 1800 or 10 a.m. to 6 p.m., which is the high time for discharges in our facility. That's the high traffic time, and we would not staff past that point. Again, this is why we recommend that it's treated like a clinic and not like an inpatient acute care unit. Volume projections for year 2, for the months 12 through 18, our maximum census would rise to 24 patients maximum. Progressive staffing would dictate that we increase our staffing to care safely for these patients. So we recommend 4 RN FTEs and 2 PCT FTEs. And these revenue projections do account for that increase in staffing and the increase in supply that would be required by the increase in census. By the end of the second year, we would be hopefully running at maximum capacity with 36 patients between the hours of 10 and 6. Progressive staffing at that point would result in an increase in 1.5 RN FTEs for a total and final staffing level of 5.5 RN FTEs and 2 PCT FTEs. In year 2, our estimated revenue would cause the project to break even around month 14 of the project, which would be August to September of the second year. In addition, year 2's reclaimed revenue totals in projections up to $385,000 during that single year, not operating at maximum capacity quite yet. In year 3, with a 36 patient maximum and a final staffing grid of 5.5 RN FTEs to PCT FTEs, we can see up to $615,000 in recovered revenue due to increases in efficiency and increases in throughput. This more than justifies, just financially, the implementation of the discharge lounge. But if you needed more reasons, other than cost savings, our Press Ganey improved patient satisfaction could result in further reimbursement from Medicare, Medicaid, and other government and insurance agencies. Our education rates will increase because of the time that will be dedicated to specific patient education by the staff RNs in this area, specifically for bundled DRGs. So although we don't have a significant problem with heart failure readmission rates at this time, there's always room for improvement. We don't necessarily have a big problem with readmission rates for sepsis patients. There's always room for improvement. After all, the point of the discharge lounge, as is the point of everything else that we do at this facility, is patient safety and patient care. Not only will this discharge lounge save us money up to 13.6% per year in lost revenue, but it will provide a convenient, a safe, and a comfortable area for patients to wait for their family and receive extra care. Specifically, the discharge lounge is associated for the project team. It's associated closely to the mission, vision, and value statements of our healthcare system. Specifically, the value statement, we never settle. We can do better, and we can give our patients better. Questions? Okay, let me show you. These are my references, and if you would like to see the extended comprehensive strategic and marketing plan, I have handouts available.